Ankylosing spondylitis belongs to a group of disorders called seronegative spondyloarthritis, or we call them spondyloarthropathies. Spondyloarthritis is a group of disorders which have a common clinical symptoms and genetic features. And the two signature features of spondyloarthropathies is absence of rheumatoid factor and strong association with HLA-B27 allele. So to understand the nature of ankylosing spondylitis, first of all, we have to know what is it seronegative spondyloarthritis. On this page, we can see the explanation and classification of spondyloarthropathies. But personally, I find this information quite difficult to understand in written form. So let's illustrate this information in form of a graph, and maybe it will be easier for us. So, we have a group of disorders called spondyloarthritis, or we call them spondyloarthropathies. It's the same thing, but it will help us to memorize that it's a multiple disorders which are united by the common features. The first common feature of spondyloarthropathies is absence of rheumatoid factor. It's the reason why we call them seronegative. In addition to this, the second major diagnostic feature is the presence of HLA-B27 allele. It's the major diagnostic marker of spondyloarthritis. These two features combined are the major serological markers that help us to make the diagnosis. Clinically, spondyloarthropathies can affect axial skeleton, which manifest as spondylitis or sacroiliitis, but also they can affect peripheral joints, which manifest as enthesitis, dactylitis, or peripheral arthritis. And the third common feature is that spondyloarthropathies are associated with systemic disorders. Most commonly, it's inflammatory bowel disorders as Crohn's disease or ulcerative colitis, and also uveitis. So, simply speaking, persons with spondyloarthropathy have a higher chance to have ulcerative colitis or uveitis compared to general population, and persons with Crohn's disease, for example, have a higher chance to be affected by ankylosing spondylitis compared to general population. On this image, we can see the full list of manifestations. Most common axial manifestations are sacroiliitis and spondylitis. Most common peripheral manifestations is peripheral arthritis and enthesitis, and systemic manifestations are uveitis, psoriasis, and inflammatory bowel disorders. Now, spondyloarthropathies are subdivided based on predominantly affected joints, on axial and peripheral. In axial spondyloarthropathies, the major symptom is a back pain, which means that the most severe inflammation occurs in axial skeleton. But spondyloarthritis can also be peripheral. In this case, the most severe inflammation occurs in peripheral joints. So, in peripheral spondyloarthritis, the most severe inflammation occurs in the joints outside axial skeleton. For example, it's a knee joint or shoulder joint. To peripheral spondyloarthropathies belong psoriatic arthritis, reactive arthritis, and enteropathic arthritis. Now, in axial spondyloarthritis, there are two possibilities. If back pain predominates and person is rheumatoid factor negative and HLA-B27 positive, but on X-ray we do not see signs of sacroiliitis, we call it non-radiographic spondyloarthritis. But if X-ray signs of sacroiliitis are present, we call it radiographic spondyloarthritis or ankylosing spondylitis. It's the same thing. Moreover, non-radiographic spondyloarthritis with time can progress into ankylosing spondylitis. What do we mean by this? Here we can see an X-ray of the sacroiliac joints. On the first image, there are no signs of sacroiliitis. So in this case, if person will have back pain, it will be non-radiographic spondyloarthritis. But with time, disease can progress, and on next images we can see inflammation of the sacroiliac joint. and inflammation with time can even cause fusion of the sacroiliac joint. This condition we call ankylosis, and now this condition will be called ankylosing spondylitis. Now, what is interesting in spondyloarthropathies is that person can have ankylosing spondylitis, but at the same time he can have features of psoriatic arthritis or enteropathic arthritis. Moreover, person with ankylosing spondylitis has a higher chance to be affected by other spondyloarthropathy compared to general population, simply because they have a common genetic predisposition and links in pathogenesis. So, what is the pathogenesis of spondyloarthritis and ankylosing spondylitis in particular? In the intestine, we have a lot of bacteria, and bacteria have a specific antigens. In normal condition, intestinal bacteria remain in the intestinal lumen. The reason is that we have intestinal barrier which do not permit intestinal bacteria to leak into the bloodstream. But some disorders can cause increase in permeability of intestinal barrier. And the most common disorders which cause increase in intestinal permeability are ulcerative colitis and Crohn's disease. Inflammatory bowel disorders cause severe inflammation in the intestine. With inflammation, the integrity of intestinal barrier becomes disrupted, which causes significant increase in barrier permeability for intestinal bacteria. In these circumstances, some bacteria can leak into the blood. In response to bacteria, our immune system becomes activated. A proper immune response results in elimination of bacteria. But bacteria destruction results in release of bacterial antigens into the blood. Immediately after bacterial antigens are released, macrophages phagocyte bacterial antigens and present some parts of the bacterial antigens on MHC1 receptors to T helpers. The logic is that antigen-presenting cells want to know, are bacterial antigens normal material or it's something pathogenic? T helpers scan antigens, and in normal condition, T helper do not trigger immune response. They just memorize information about this bacterial antigen. But in some people, T helpers can be overreactive to bacterial antigens. The problem here is that some individuals have MHC1 receptors that are produced based on HLA-B27 allele, and such MHC1 receptors present bacterial antigens in an unusual way. In these circumstances, T helper exaggerates the danger, and in response to bacterial debris, they begin a full immune response that will have dramatic consequences. So, in individuals with MHC1 receptors that are made based on HLA-B27 allele, in response to bacterial antigens, T helpers becomes fully activated. Once T helper becomes activated, T helper induces activation of B lymphocytes. If B lymphocytes becomes activated, they begin to produce antibodies. In this case, B lymphocytes begin to produce antibodies against bacteria. It's anti-Klebsiella pneumonia antibodies, also it's anti-CD74 antibodies and anti-sclerostin antibodies. At the same time, T helpers activate T killers. In response to this, T killers infiltrate soft tissues. Now, there is one small problem with antibodies. In soft tissues, we have a lot of glycoproteins, and some of these glycoproteins can structurally look very similar to bacterial antigens. This phenomenon we call molecular mimicry, and in this case, antibodies against bacteria can mistakenly bind also to glycoproteins in the soft tissues. This results in severe soft tissue injury, and usually soft tissue injury manifests as uveitis or psoriasis. On this image, we can see uveitis in patients with ankylosing spondylitis. As we see, uveitis typically cause red eye, and under the microscope we see a lot of inflammatory cells that infiltrate cornea, and it's a sign of severe inflammation. Additionally, activated T helpers induce activation of T helper subtype 17. This activation is possible due to the massive production of interleukin-23 by T helpers. With activation, subtype 17 T helpers begin to produce proinflammatory cytokines, including interleukin-17 and TNF-alpha. And last but not least, activated T helpers induce activation of macrophages. With activation, macrophages begin to produce massive amount of TNF-alpha and interleukin-6. So, inflammatory reaction results in massive production of proinflammatory cytokines, and exactly proinflammatory cytokines will be responsible for all other clinical symptoms. Let's discuss the effect of proinflammatory cytokines separately in details. First of all, proinflammatory cytokines cause severe inflammation, and the markers of severe inflammation is elevation of C-reactive protein and increase in erythrocyte sedimentation rate. Also, severe inflammation causes general symptoms, as fever, chills, fatigue, and weight loss. Severe inflammation can also provoke extraarticular manifestations. The most common extraarticular manifestation is uveitis. Uveitis typically affects just one eye. It causes red eye, pain, and photophobia. In addition to this, proinflammatory cytokines can also affect aortic valve, which can cause aortic regurgitation. Proinflammatory cytokines also stimulate the activity of osteoclasts, which in response to this begin to destroy bones. Progressive bone destruction leads to osteitis, and in turn, osteitis leads to arthritis. In ankylosing spondylitis, the most severe arthritis occurs in sacroiliac joints and vertebral column. Now, severe inflammation and arthritis combined stimulate the nociceptive receptors in affected joint, which causes severe pain. And there are several signature features of pain in ankylosing spondylitis. Pain has insidious onset, it improves with exercises, occurs typically at night, and the most common sites of pain is lower back, hip, and buttocks. In response to osteitis, osteoblast becomes activated. Osteoblasts begin to produce new bone tissue, but osteitis combined with neosteogenesis with time can cause enthesitis. On this image, we can see the pathogenesis of enthesitis. At first stage, mechanical injury or autoimmune-mediated injury cause inflammation. Inflammation leads to vasodilation. With vasodilation, proinflammatory cells come to the site of injury, where by the release of proinflammatory cytokines, they activate osteoclasts. And with activation, osteoclasts begin to destroy bone tissue. In response to inflammation and activation of osteoclasts, mesenchymal tissue begin to proliferate, and in the same time, osteoblasts begin to produce new bone tissue in a process called neosteogenesis. And exactly neosteogenesis can cause fusion in the sacroiliac joint or fusion of the vertebra, which is the signature feature of ankylosing spondylitis. So, clinically, enthesitis manifests as tenderness at sites where tendon attaches to the bone, and usually enthesitis affects Achilles tendon, plantar fascia, and tibial tuberosity. In the vertebra, prolonged enthesitis leads to formation of a new bone tissue, which we call syndesmophytes. First of all, formation of a new bone tissue significantly increases the risk of fractures. In addition to this, overgrowth of the new bone tissue in the spine can lead to a fusion of the vertebra, a condition known as bamboo spine. So, on the left, we see normal spine. Look at the spaces between each vertebra. But on the right, we can see images from a patient with ankylosing spondylitis, and look at the spaces between the vertebra. Such decrease in space between the vertebra is caused by the overgrowth of the new bone tissue, which we call syndesmophytes, and exactly such spine we call bamboo spine. On next image, we can see normal spine, and here we can see bamboo spine. Such overgrowth of the new bone tissue forms so-called bridges between the vertebrae, and exactly these bridges give the bamboo spine appearance. Here we can see normal spine, and on this image we can see bridges between the vertebrae that give a spine the bamboo appearance. And on next image, look at the space between the vertebrae. Compared to normal state, there is no space between vertebrae at all. Also recall that joint fusion is possible not only in the spine, but also in the sacroiliac joints. Here we can see sacroiliac joint in normal state. And on next images, we can see step-by-step progression of ankylosing spondylitis, which in the end results in complete fusion of the sacroiliac joint. Clinically, bamboo spine manifests as decrease in chest expansion, which can cause decrease in total lung capacity, and also it causes decrease in spinal range of motion. So let's depict on this image the most important steps from what we have discussed. So all these proinflammatory cytokines through signaling pathways induce activation of osteoclast. And we have to know that one of the crucial signaling pathways involved in activation of osteoclast is Janus-Kinase pathway, also called JAK pathway. With activation, osteoclasts begin to produce proteolytic enzymes, which begin to progressively destroy bone tissue. This process we call bone resorption, and in ankylosing spondylitis, bone resorption primarily affects vertebra or sacroiliac joints, which results in osteitis. Osteitis, by compensatory mechanism, leads to activation of osteoblasts, which begin to produce new bone tissue in a process called reactive neosteogenesis. At the same time, such severe inflammation also affects endocytes, which leads to enthesitis. Clinically, the most important symptom which tells us about ankylosing spondylitis is a back pain, and important that back pain here is caused by inflammation. Because it's inflammatory pain, it becomes worse in the morning after the prolonged periods of inactivity, and important that pain improves with exercises. So the most typical complaint is that patient will tell you that he has difficulty sleeping, and pain is not relieved with rest or lying down. Gluteal pain is a specific feature of sacroiliitis. Also sometimes pain can even occur in the mid-thoracic region and cervical region. Because it's inflammatory pain, intake of non-steroidal anti-inflammatory drugs can provide significant pain relief, which is also one of the diagnostic features. And generally, if patient has one of the associated conditions, as psoriasis or inflammatory bowel disease or uveitis, he has a higher chance to be affected by ankylosing spondylitis compared to general population. So let's summarize the pathogenesis. Ankylosing spondylitis causes the most severe inflammation in spine and sacroiliac joints, which results in joint fusion or so-called ankylosis. Ankylosis in spine we call bamboo spine. In some cases, ankylosis can even cause restrictive lung disease, and recall that restrictive lung disease we can determine by decrease in total lung capacity and vital capacity. This disorder mostly affects young people between 20 and 40 years old, and the most common extra-articular manifestations are uveitis and aortic regurgitation. But how do we treat? The first-line drugs in treatment of ankylosing spondylitis are non-steroidal anti-inflammatory drugs. So, if we prescribe classic non-steroidal anti-inflammatory drugs as ibuprofen or diclofenac, or selective COX-2 inhibitors as celecoxib, they block the production of proinflammatory cytokines, which is the central step in pathogenesis of ankylosing spondylitis. We can also use glucocorticosteroids, and we can use sulfasalazine in case of ankylosing spondylitis accompanied by peripheral arthritis. In the most severe cases with high disease activity, we use TNF inhibitors, interleukin-17 inhibitors, or JAK inhibitors. As we see from pathogenesis, this makes sense, because TNF, interleukin-17, and Janus kinase pathway are the crucial factors which stimulate the activity of osteoclast, and by this they promote the entire pathogenesis of ankylosing spondylitis.
May the Force be with you.